Hello everyone, this video is about hypersensitive reactions or hypersensitivity, and I hope you have a previous experience or you are preoccupied with the knowledge about this hypersensitivity. And I'm taking this class assuming that. So if you are not familiar with this topic, I hope you will read something about this topic and then revisit this video. So let's start. A quick recap of this particular topic. This is a pictorial depiction of various, mechanisms and classes of hypersensitivity: type 1, type 2, type 3, type 4. So if you closely gaze into this first picture, you could see portions like allergen, the receptor for IgE, antigen specific IgE, then some sort of degranulation will be taking place, degranulation. So what is happening in this case of type 1 hypersensitivity? Type 1 hypersensitivity is IgE mediated hypersensitivity. AG induces cross-linking of IgE bound to mast cells and basophils with release of vasoactive mediators. Then typical manifestations include systemic anaphylaxis and localized anaphylaxis such as hay fever, asthma, hives, food allergies, and eczema. Then there will be another type, type 2. Type 2 we could see ADCC. Then cytotoxic cell is there, FC receptor, target cell, surface antigen, complement activation will be taking place, immune complex is formed. So what is happening in case of type 2 hypersensitivity? IgE mediated cytotoxic hypersensitivity, IgG mediated. Earlier it was IgE mediated, type 1. Type 2 is IgG mediated cytotoxic hypersensitivity. So AB directed against cell surface antigens mediate cell destruction via complement activation or ADCC. AB directed against cell surface antigens mediate cell destruction via complement activation or ADCC. Typical manifestations include blood transfusion reactions, erythroblastosis fetalis, and autoimmune hemolytic anemia. Then there will be type 3. Type 3 in the sense immune complex will be there, complement activation will be taking place, and neutrophils are there. So immune complex mediated hypersensitivity. AGAB complexes deposited in various tissues induce complement activation and ensuring inflammatory response mediated by massive infiltration of neutrophils. Then typical manifestations include localized arthritis reaction and generalized reactions such as serum sickness, necrotizing vasculitis, glomerulonephritis, rheumatoid arthritis, and systemic lupus erythematosus. Then type 4 will be there. Antigen is there, sensitized to TH, cytokines are released, activated macrophage. Cell-mediated hypersensitivity, sensitized Th1 cells release cytokines that activate macrophages or TC cells which mediate direct cellular damage. Then typical manifestations include contact dermatitis, tubercular lesions, and graft rejection. So immune complex mediated hypersensitivity is the type 3 type. So AGAB complexes deposited in various tissues induce a complement activation and an ensuing inflammatory response. So we learned about that. And type 4, you could see antigen is there, sensitized to TH, cytokines, activated macrophage, and type 4, cell mediated hypersensitivity. Then cell mediated hypersensitivity is the type 4. Sensitized Th1 cells release cytokines that activate macrophages or TC cells which mediate direct cellular damage. So typical manifestation include contact dermatitis, tubercular lesions, and graft rejection. Here you could see a pictorial depiction of this. Allergen is there, CD4 is there, T cell, IL4, TH cell. Memory cells are got activated. Then plasma cell is there, allergen-specific IgE, Fc receptor for IgE, sensitized mast cell is formed along with allergen. Allergen is there, degranulation is there, vasoactive amines are formed. Which will eventually produce some sort of results like smooth muscle cell contraction, blood, small blood vessel, mucus gland, blood. In all these regions, this will be creating some sort of reaction. Blood platelets got affected, sensory nerve endings, eosinophils. So, general mechanism underlying a type 1 hypersensitive reaction, exposure to an allergen activates B cells to form IgE secreting plasma cells. The secreted IgE molecules bind to IgE specific Fc receptors on mast cells and blood basophils. Many molecules of IgE with various specificities can bind to the IgE Fc receptor. Then second exposure to the allergen binds to cross-linking of the bound IgE, triggering the release of pharmacologically active mediators, vasoactive amines from mast cells and basophils. The mediators cause smooth muscle contraction, increased vascular permeability, and vasodilation. There are several components of type 1 reactions. Allergens. The majority of humans mount significant IgE receptors only as a defense against parasitic infections. After an individual has been exposed to a parasite, serum IgE levels increase and remain high until the parasite is successfully cleared from the body. The term allergen refers specifically to non-parasitic antigens capable of stimulating type 1 hypersensitive responses in allergic individuals. So that's about allergens. After an individual has been exposed to a parasite, serum IgE levels increase and remain high until the parasite is successfully cleared from the body. The term allergen refers specifically to non-parasitic antigens capable of stimulating type 1 hypersensitive responses in allergic individuals. Then next, reagenic antibody or IgE. Serum IgE levels in normal individuals fall within the range of 0.1 to 0.4 mg per ml. Even the most severely allergic individual rarely have IgE levels greater than 1 mg per ml. So IgE was found to be composed of 2 heavy and 2 light chains with a combined molecular weight of like this 1,90,000. The higher molecular weight as compared with IgG is due to the presence of an additional constant region domain. This additional domain contributes to an altered combination of the Fc portion of the molecule that enables it to bind to glycoprotein receptors on the surface of basophils and mast cells. Although the half-life of IgE in the serum is only 2 to 3 days, once IgE has been bound to its receptor on mast cells and basophils, it is stable in that state for a duration of a number of weeks. Then IgE cross-linkage initiates degranulation. So allergen cross-linkage of cell-bound IgE. Allergen is there, IgE Fc receptor, IgE will be there, mast cell is there. Then some sort of cross-linking will be taking place. Then next this picture B. Antibody cross-linkage of IgE, anti-isotype AB, then anti-idiotype AB. Then next chemical cross-linkage of IgE, cross-linking chemical. Then cross-linking of IgE receptor by anti-receptor antibody, anti-receptor AB will be there. Along with that, enhanced Ca2 plus influx by ionophore that increases membrane permeability to Ca2 plus. Ionophore is there, Ca2 plus is released. So systemic diagrams of mechanisms that can trigger degranulation of mast cells. Note that mechanisms B and C do not require an allergen. Mechanism D and E require neither allergen nor IgE. The mechanism does not even require receptor cross-linkage. Then type 1 reactions can be systemic or localized. Systemic anaphylaxis, localized anaphylaxis, atopy. Allergic rhinitis results from the reaction of airborne allergens with sensitized mast cells in the conjunctiva and nasal mucosa to induce the release of pharmacologically active mediators from mast cells. These mediators then cause localized vasodilation and increased capillary permeability. Then asthma. In some cases, airborne or blood-borne allergens such as pollens, dust, fumes, insect products, or viral antigens trigger an asthmatic attack or allergic asthma. In other cases, an asthmatic attack can be induced by exercise or cold, apparently independently of allergen stimulation, intrinsic asthma. Like hay fever, asthma is triggered by degranulation of mast cells with release of mediators, but instead of occurring in the nasal mucosa, the reaction develops in the lower respiratory tract. The resulting contraction of bronchial smooth muscle lead to bronchoconstriction. Then food allergies are there. Various foods also can induce localized anaphylaxis in allergic individuals. Allergen cross-linkage of IgE on mast cells along the upper or lower gastrointestinal tract can induce localized smooth muscle contraction and vasodilation, and this such symptoms as vomiting or diarrhea. Then atopic dermatitis. Atopic dermatitis or allergic eczema is an inflammatory disease of skin. The allergic individual develops skin eruptions that are erythematous and filled with pus. We could see a sensitization reaction. Sensitization in the cell. Skin testing by intradermal injection of allergens into the forearm. In this individual, a wheal and flare response developed within a few minutes at the site where grass was injected, indicating that the individual is allergic to grass. Several methods are used to detect type 1 hypersensitivity response or reactions. Like the advantage of skin testing is that it is relatively inexpensive and allows screening of a large number of allergens at one time. The disadvantage of skin testing is that it sometimes sensitizes the allergic individual to new allergens. And another method of accessing type 1 hypersensitivity is to determine the serum level of total IgE antibody by the radioimmunosorbent assay or RIST. This highly sensitive technique based on the radioimmunoassay. Paper disc or agarose bead, anti-IgE coupled to solid phase, patient IgE, radio labeled anti-IgE, then cell bound label. Radioallergosorbent test. We mentioned this, I guess. No, we need to mention this. Detects the serum levels of IgE specific for a given allergen. So allergen coupled to solid phase, patient IgE, bound allergen specific IgE. The non-specific IgE is washed away, radio labeled anti-IgE, then count blood label. The next, antibody mediated cytotoxic type 2 hypersensitivity. Type 2 hypersensitive reactions involve antibody mediated destruction of cells. Antibody can activate the complement system, creating pores in the membrane of a foreign cell, or it can mediate cell destruction by antibody dependent cell mediated cytotoxicity. Antibody mediated cytotoxic type 2 hypersensitivity. Type 2 hypersensitivity reactions involve antibody mediated destruction of cells. Antibody can activate the complement system, creating pores in the membrane of a foreign cell, or it can mediate cell destruction by antibody dependent cell mediated cytotoxicity or ADCC mechanism. And transfusion reactions are type 2 reactions. Hemolytic diseases of the newborn is caused by type 2 reactions. Hemolytic disease of the newborn develops when maternal IgG antibody specific for fetal blood group and antigens cross the placenta and destroy fetal red blood cells. The consequences of such transfer can be minor, serious, or lethal sometimes. Several hemolytic diseases of the newborn, called erythroblastosis fetalis, most commonly develops when an Rh positive fetus expresses an Rh negative antigen on its blood cells that the Rh negative mother does not express. Then drug-induced hemolytic anemia is a type 2 response. Certain antibiotics like penicillin, cephalosporin, and streptomycin can absorb non-specifically to proteins on RBC membranes, forming a complex similar to a Hampton carrier complex. In some patients, such drug-protein complexes induce the formation of antibodies which then bind to the absorbed drug on red blood cells. inducing complement-mediated lysis and thus progressive anemia. When the drug is withdrawn, the hemolytic anemia disappears. Here you could see the picture which depicts this erythroblastosis fetalis, or the hemolytic disease of the newborn, caused when an Rh negative mother carries an Rh positive fetus, and the effect of treatment with anti-Rh antibody or ROGAM. Development of erythroblastosis fetalis without ROGAM. I'm not sure about the pronunciation of this thing. Sorry. RBCs with Rh antigen, first pregnancy, placenta, maternal circulation, then delivery, mother, Rh specific B cells, plasma cell, anti-Rh IgM, memory cell, second pregnancy, memory cell, IgG, plasma cell, IgG, anti-Rh AB crosses placenta and attacks fetal RBCs, causing erythroblastosis fetalis. Then prevention with ROGAM. Mother treated with ROGAM, B cell ROGAM prevents B cell activation and memory cell formation. Then immune complex mediated type 3 hypersensitivity. Much of the tissue damage in type 3 reactions stems from release of lytic enzymes by neutrophils as they attempt to phagocytose immune complexes. As the reaction develops, localized tissue and vascular damage results in an accumulation of fluid, edema, and red blood cells, erythema, at the site. The severity of the reaction can vary from mild swelling and redness to tissue necrosis. So, generalized type 3 reactions were often observed after the administration of antitoxins containing foreign serum, such as horse anti-tetanus or anti-diphtheria serum. In such cases, the recipient of a foreign anti-serum develops antibodies specific for the foreign serum proteins. These antibodies then form circulating immune complexes with the foreign serum antigens. So typically within days or weeks after exposure to foreign serum antigens, an individual begins to manifest a combination of symptoms that are called serum sickness. These symptoms include fever, weakness, generalized vasculitis or rashes with edema and erythema, lymphadenopathy, I'm not sure of the pronunciation, lymphadenopathy, arthritis, and sometimes glomerulonephritis. Then type 4 or delayed type hypersensitivity. And some subpopulations of activated Th cells encounter certain types of antigens. They secrete cytokines that induce a localized inflammatory reaction called a delayed type hypersensitivity or DTH. The reaction is characterized by large influxes of non-specific inflammatory cells, in particular macrophages. This type of reaction was first described in 1890 by Robert Koch, who observed that individuals infected with Mycobacterium tuberculosis developed a localized inflammatory response when injected intradermally with a filtrate derived from a Mycobacterium culture. He called this localized skin reaction a tuberculin reaction. And then the hallmarks of a type 4 reaction are the delay in time required for the reaction to develop and the recruitment of macrophages as opposed to neutrophils as found in the type 3 reaction. So macrophages are the major component of the infiltrate that surrounds the site of inflammation. Many contact dermatitis reactions, including the response to formaldehyde, trinitrophenol, nickel, turpentine, and active agents in various cosmetics and hair dyes, poison oak and poison ivy, are mediated by Th1 cells. Most of these substances are small molecules that can complex with skin proteins.